All right, welcome guys. We are going to cover the Terrain Program 2026 as it is now and kind of discuss a little bit of the evolution of our Integrative Cancer Support Program. I am going to keep my screen like this so I can actually see your questions come through live. All right, here we go. So you might notice this logo. This is our terrain support logo. So anything tied to our program is going to have this, obviously the terrain of the mountains. So why do we call it terrain? That's a really good question right up front, and I will get to that. So that's gonna be the first thing we're gonna cover tonight. We're gonna talk about why we offer a terrain program at all. It was a big decision that we made. It's had some repercussions on us as a practice, but I'm gonna explain kind of how that has evolved since the beginning and why we got into it in the first place. We're going to talk about our three-pillar approach to integrative cancer support. Everyone should know what to expect from us when they come and what we're going to do. What is our role in your team? Unfortunately, when someone has a diagnosis of cancer, the world just kind of spins and things happen very quickly. So we want to slow that down for people and really clarify expectations where we fit into things. One of the common questions we get is how do you work with the standard of care teams, and I'll call them the SOC teams. Tonight, how do we work with traditional medical oncology, radiation oncology, surgeons, anybody on like the system side of the aisle? And I can address that for you. Please sign me up for this. Okay, Karen, we will get you on that. So what kind of cancers can we help with? This is going to be important. And then I'm going to go over the HOPE protocol. So if you're sitting there tonight and saying, well, I don't have cancer, this isn't an issue to me, you might want to hang out anyway. Some of this applies to all of our patients, and everybody knows somebody who has a cancer diagnosis, or you will know somebody that may benefit from what we have to offer. So appreciate you hanging out with us tonight, even if it doesn't clearly apply to you on the surface. So what is terrain? This is actually a term we got from Dr. Nasha Winters. She is a naturopathic physician. I don't know if you guys, how many people know her history? Give me a thumbs up here, or raise your hand, or give me yeah. If you've heard of Dr. Nasha Winters, because a lot of what we do is actually based on her work. Okay, so when she was in her teens, plan was to go to medical school, become a physician, and she was diagnosed with ovarian cancer, I believe, very early on. And around age 19, I believe she had some recurrence or advancement and was told to pick her hospice. She didn't accept that. And so she began doing her own research, treating herself, and now has developed into the metabolic approach to cancer, looking at it from a terrain perspective. So, what does that mean? Cancer grows in an environment. So your body is the petri dish that this grows in. So that terrain, the sum total of all the lumps and the bumps and the highs and the lows of that petri dish is what we are working on. So that is what the terrain is. We are working on your body. We are working on you. So one of the things that I laugh because it's almost predictable. The minute somebody has a cancer diagnosis, everybody's attention goes to the cancer. It goes to tumor markers, it goes to pathology reports, imaging studies, and sometimes people kind of forget there's a person sitting there in front of them. We forget about things like diabetes management and inflammatory markers and nutrition. So we kind of bring that back full center. We keep the patient at the center of the focus. The cancer people can focus on the cancer over here. We're going to keep our focus on you to help you get through this the best we can. This is a slide I borrowed from Dr. Verone of the IMA. There is the Ethical Skeptic is a wonderful follow on Twitter if you like this kind of thing. This is an account, I don't know who it is, but has been tracking cancer incidents since the beginning of COVID, and it's explosive. You can see right here in 2020, it jumped up pretty high. So I think you can make the argument COVID impacted it, but the shots have impacted it even more. So we absolutely have an epidemic of cancer right now. Turbo cancers are real. We've heard repeatedly that there are patients with stage 4 cancer that when they make it to the funeral home, they don't even look like a cancer patient because they never have treatment long enough. So those are really things that are happening in the world. So what is our experience and background? A lot of people forget, myself included, that I used to be a general surgeon. So for the first 7 years of my training as a surgery resident and critical care fellow, I participated in tumor boards and tumor operations all the time. My early training was spending 2 to 3 times a week. We had the breast tumor board and we had general tumor board. So I spent a lot of time taking care of these patients, talking to all the collaborating physicians. And then I was actually in practice for 6 years where I led and participated in tumor board with my own cases. So been there, done that. Had a very busy breast surgery practice at one time when I was a surgeon in Joplin, Missouri. So very rich background in oncology to start with. I was actually contemplating becoming a surgical oncologist. Thank God I did not. So my interest in that ran deep at the time. One of my mentors was a surgical oncologist. It was a big deal. So as we broke from the mold, launching James Clinic in 2021, patients were asking for ivermectin. And it was kind of this very natural evolution that they wanted ivermectin for COVID, and then they wanted IV vitamin C for COVID, and then they were kind of starting to trickle in for other things. They didn't want statins, and then patients wanted ivermectin for cancer. And that started to pick up very aggressively. And there was a lot of overlap in what we were doing in just our regular integrative space and in the integrative cancer space. But I said, if we're going to do it, we're going to do it right, and we're going to do it all the way. So we invested heavily in training through Dr. Nasha Winter's course. It's a year-long course for clinicians on one hand, extremely intense, time-consuming. And I also put the majority of my staff through a nurse advocate program so that we could all be on the same page, talking the same lingo, have consistency, and all pull this forward for patients in the same manner and direction. So around the same time, FLCCC started talking about cancer care. Dr. Merrick wrote his book. I'm now a senior fellow with the IMA, so that kind of dovetails nicely into kind of where things are going. So our program is unique. When people ask if we follow so-and-so's protocol, no, we don't. We call it my protocol or roadmap because I don't believe any one person's protocol per se is right. So we have 3 pillars that we're built on. Pillar 1 is taking a comprehensive look at the patient. This is really what we do for every single patient that comes across our path. We want to optimize for all of the basic things, looking at everything from cholesterol. Obviously, if you're dealing with a stage 4 cancer diagnosis, your cholesterol isn't my main concern, but it gives me context for all of the other labs to know which levers to pull to help you get better. Things like homocysteine. I've had a cancer patient with a homocysteine level over 200. We have to get that corrected before we can think any of these treatments are going to work. So we do our basic deep dive comprehensive look. Pillar 2 is mitigating damage. So almost every single patient that participates in standard of care therapy has damage. We can, using our integrative approaches, really help those treatments work better and reduce the side effects and complications from those. And then pillar 3 is outside of the box treatments. That's really what everybody thinks they're getting from us. But if you look across the spectrum, really it's all 3. So again, cancer steals the spotlight once a diagnosis is made. And what really upsets me is when patients have this, obviously it's very shocking, it's very stressful, very emotional because we've been taught cancer creates an emotional response. If I told you you had chronically fermenting cells, you're probably not going to get too excited, right? Because you don't know what they are. Chronically fermenting cells, that's actually what cancer is. They burn sugar instead of oxygen in the normal fuels. So we have been programmed to have this automatic knee-jerk response that I have this, I need chemotherapy and radiation and surgery and blah, blah, blah. Keep in mind that many standard of care therapies don't work unless the body is optimized. So the immunotherapies that are now being prescribed with more and more frequency, you need an optimal vitamin D level. And do you know how many patients I've had come in with a vitamin D level checked? I think 0. So we're going to cover all of those bases for you while the other doctors are looking at what they are specializing in. So here's the Terrain 10. This is Dr. Nasha Winter's program. So some of these things we're really heavy on and some of them we're a little bit lighter on. Genetics and epigenetics, we're probably a little lighter on that one. Blood sugar balance and metabolism, we're very heavy on. Toxic burdens, we're medium. Microbiome and digestive, we're very aggressive. Immune function, very aggressive. Inflammation, very aggressive. Blood circulation and angiogenesis, very aggressive. Hormone balance, yes. Stress and biorhythms, yes. And then probably the most important take home you can have out of tonight's talk is that patients who tend to have the best recovery actually deal with the last one, the mental and emotional. So all of us have trauma, and it doesn't have to be real trauma. It doesn't have to be you witnessed something terrible, or you were in a war, or you were a victim of a crime. It can be something as simple as a comment that was made when you were a child that your brain processed a specific way. You have to you got to clean out the pipes. You got to get all that junk out of there because our body stores all of that damage in our tissues. So that's probably where we're the lightest. We encourage people to go deal with it. It's not, we don't have counselors and mental health folks on our team. And a lot of our patients have gone to people and are working on that. And we see the improvement when that happens. So really, really important part. And it's like everybody's least favorite. Tell me what supplements to take, tell me what to eat, but I don't want to talk about, what somebody did to me when I was 4. Understandable. All right, pillar 2, mitigate damage. So standard of care therapies are toxic by design, right? They're trying to kill cells and they want to kill the cancer faster than they kill you. And I actually joke about that and say it that way. Like I said, our approaches can help patients so they don't look like or feel like a cancer patient per se, which is really important. Somebody today was just telling me, like, I'm tired of people asking me how I feel. Stop treating me different. So if we can maintain, they can keep working, they can keep parenting, they can still look like themselves, like they don't get that. It's really good for their mental well-being. What really lights my fire is when you hear about cases, like all of our patients do better than trajectory, like their trajectory is better than expected. All of them, every one of them. And so when they go back to their standard of care doctors, that's why we like people to be plugged in. Like it's actually a requirement of mine that everyone sees a medical oncologist and radiation oncologist as appropriate for each case. Those doctors see patients doing better. And sometimes they ask, what are you doing? What are you doing? I didn't expect you to look this good. And when they tell them, you would think that doctor, having their patient's best interest in mind, would then share that with other people. Hey, the patients who do this, this, and this seem to do better. Let's get you plugged in with that. Instead, they just say, don't tell me any more about that. Just keep doing what you're doing. And it's like, turn a blind eye. Like, I know you're doing that crazy stuff, but it's working and we're taking credit for it, so it's fine. Just keep that in mind. The most common side effects for standard of care therapy are things like fatigue, huge. Neuropathy, huge. We're really, really good at turning around neuropathy, by the way. Nausea, immune dysfunction. How many people have had to stop their standard of care therapy because their white blood cell count dropped to dangerously low levels? And the only thing for that is give you a shot to pop it back up, kind of automatic or artificially. Losing weight, malnutrition, radiation burns. Did you know when you have radiation, it is FDA approved for them to offer you hyperbaric oxygen? You could do it in their hospital. Now, they charge 100x, I think. Like, it's ridiculous what they charge for that. And most people won't even give it to them. I need a slide in here that's like the top 10 craziest things that people have said to our patients, but one of them is like hyperbaric will blow the cancer all over your body. That's the dumbest comment I think I've ever heard regarding this. Again, a lot of tissue damage, a lot of GI issues, diarrhea, nausea, vomiting, constipation. It can go either way. And then the mouth sores. So I don't think we have anything for the hair loss piece of it yet. And then outside of the box therapies. So these are the things people think of that we do. There's this bias that we have, and we have to address this, and we hear it all of the time. When our patients go and their things progress, well, that didn't work. That's hocus pocus, blah, blah, blah. But when you do standard of care and the tumor progresses, well, that's just a difficult case. That's just an aggressive tumor. So the entire jargon of everything in the industry blames us for their problems and takes credit for our wins. That's okay. We're fine with that. But patients need to remember that. And patients who choose to go down both roads have to be really strong because sometimes they'll go to standard of care, they'll get a perspective they don't like, they'll get disrespected, and they'll get news they don't like. Within the last week, I've had 2 or 3 patients whose doctors told them this is hocus pocus. They're just trying to take your money and stop everything. Or you're not going to be able to get the real treatment when your liver enzymes blow up. That's really disappointing to hear, but my solution for that isn't to address that and try to convince them. It's just show them, right? Scoreboard. Show them our patients that are doing better. And eventually, what will happen is somebody they care about is going to get sick, personally care about, I should say, and they're going to want to know. Trust me. So, why doesn't system medicine offer these outside of the box therapies? So I think more and more so, we're all seeing that they have blinders on. And what the system of medicine offers are things they can bill for that have CPT codes and ICD-10 codes and charges that are good profit centers. So if something doesn't fall into those 4 things, they're not going to offer it. So nobody stands to make a fortune with ivermectin, with IV vitamin C, with mistletoe. So your botanicals, your generics, your non-patentable things are never going to be offered by standard of care. It's just not going to happen. There's no incentive. There's no big studies. It's not going to make its way. They don't sponsor big pharma conferences. So every single thing that we offer in our office has evidence. Maybe small evidence. It may be anecdotal. It may be from Europe. It may be adjunctive, but there is evidence for every single thing that we do. So when those standard of care doctors make these derogatory comments, what they're doing is they're actually displaying their ignorance. Instead of just saying, I don't know about that, let me look into it, or I don't know about that, so let's just make sure it doesn't interact, there is evidence for everything we do. So keep that in mind. So what are some of those things? And again, this is review for a lot of you. The supplements. So we have the foundation. That is a mitochondrial support multivitamin. Fish oil is anti-inflammatory. If you look in the textbooks, we pull from 3 different textbooks. This is one of the keys for most treatment protocols. Vitamin D. There's a mountain of evidence for vitamin D in cancer. Vitamin D is a hormone that drives the immune system. So if your vitamin D is sub 80 and you're going through a process, we need to address that. Vitamin C, we use that. We used to use it a little bit more. We've become more selective. So it's patient specific now. If somebody's getting IV vitamin C infusions in our office, we prefer they take oral vitamin C every day, 10 to 12 grams. And they need to do that in a specific way. The reason they do that is so we can fill your buckets of vitamin C. Then when you get your infusion, we can launch you up into therapeutic ranges, because our body needs a lot of vitamin C. So if you're not taking it and you're doing vitamin C infusions, your body absorbs all of that vitamin C. It's really hard to get that level up where it needs to be because your body's just sucking it up. Melatonin, I did an entire review on melatonin. It is like the #2 antioxidant in the body behind glutathione. It also is a weak aromatase inhibitor. So if you have a hormone-sensitive cancer, it does some things to change the ratio of metabolism from testosterone to estradiol. It's got, again, about 17 different mechanisms. Antioxidant, starves the tumor, stops angiogenesis or blood vessel formation. So this is one of our secret weapons. It's so easy to integrate into what you're doing. It does make some people tired, but we have solutions and troubleshooting for all of that. Our IV therapies are really good. So IV vitamin C, we start with like nutritional support, and then we do the high C for cancer. There's some debate whether high C actually kills cancer cells or if it just supports the immune system to help do that indirectly. Some of you have had ALA or alpha lipoic acid, again, a powerful antioxidant. It also helps with neuropathy for most of our patients. And CBD is endocannabinoids. This helps regulate the immune system. It helps with sleep and it helps with pain. So just kind of helps your body kind of exhale and calm down. Hyperbaric oxygen, I actually only recommend this in specific instances where I know there's benefit. Anybody who wants to add it, I'm always supportive of that, but the people specifically I highly recommend do it is anybody post-op, anybody who's getting radiation, and anybody with any kind of brain fog. We can try the hyperbarics because it may help. Outside of that, it's a bonus add-on for most other people. The mitochondrial reboot therapy, some of you have requested. Thank you for coming tonight. You're going to get a bonus right now. I'm going to put it in the chat. This is not for distribution. This is just for you. You've been asking for the white paper for MDI use in cancer, and I just dropped it in the chat. So if you've been anxiously awaiting that, I received it. It actually came in my email over a month ago, and I'm so far behind my emails, I missed it. But now you have it, so you can read. It's 14 pages. It's the rationale for why the mitochondrial reboot therapy would be helpful and what results they've seen. Also, we now have our advanced functional testing. This is going to be really helpful for you guys who there's some of these are cardiotoxic. We're going to get into that. Stephanie, it's a PDF I just dropped above. So if you can't find it, I'll drop it again and we'll check back on that. So the advanced functional testing, if you are taking a therapy that is cardiotoxic, we might want to do an MCG and see, are we seeing any stress signs in your heart that maybe won't be picked up until there's damage? We want to get out of that habit of waiting until it's too late, until the damage is done. We want those early warning signs and we want to know what is coming down the road. So what does our program look like? Like, what do you actually get with our James Clinic Terrain program? Oh, that's right. PDF on Zoom is a little bit tricky. So what I'll do is, I don't know, we'll figure out some way to get that to you. So the program, when you sign up for the Terrain program, and again, if you send somebody our way, right now we've been on a wait list for about 2 months, and we've tried to let in people that we know we can help that are nearby our locations. Patients who are in person just do exponentially better. And I take a lot of pride in the fact that my team loves on our patients and cares about them. And just the environment, the energy of our office is so healing. Just to walk in somewhere where people are optimistic, and it's not blowing smoke, it's not false hope, it's just optimistic, right? We're not going to sit there and focus on the negative. We want to look at the positives because I truly believe at the end of the day, handling these issues comes down to your mentality more than anything. And as someone who is literally selling a program, that's a pretty powerful statement, right? It is your mentality, it's how you do, it's how you think about things, it's how you think about the outcome that determines the outcome. We start with a very extensive intake with our nurses. They sit down with you, they review your history. Some people are short in they just started the journey and are pre-diagnosis. Some people have been doing it for several years. And so we have to review what therapies have they had, what did they do well with, what didn't they do well with, where are we, what are the recommendations on the table, what are we actively doing, what are we saying no to. I have a team that also collects the records. Now, some of you have sent us binders that are this thick. Some of you have had your institution send us 500 or 1,000 pages of records. My team then takes the time to go through those and organize them for me because 85% of that or more is garbage. It's just EMR junk. So they get it organized and laid out for me so I can review the highlights and the important things. You then spend an hour consulting with a clinician. Sometimes that's me, sometimes that's one of our nurse practitioner or PA to again, just establish care with you, see what the priorities are, and get you started on treatment. So sometimes there isn't a lot I can do right up front out of the gates. We need to get the labs ordered. We need to get your nutritional status. We need to get, if you have a neuropathy, we need to get you in doing some other things. So then when I come in and see you, I can actually review those labs and give you a formulated plan. So there's a lot of work we need to do up front, even before you see me. Then you'll see me at some point early on, and I'll review everything. We'll refine recommendations. You'll get a monthly touch point with the nurses, if not with me. We're trying to get to once things are stabilized, you'll be on about every 3-month follow-up with me. That's pretty standard in the industry. We also have the weekly education Mondays at 9 a.m. So the nurses are going through that terrain step by step. So that's your deeper dive. That's the stuff that we don't have time during an appointment to go through, that you're getting that deep focused intervention on. We added the Monday webinars. So that's what we're doing tonight, to deep dive on those topics, on things people ask me about, like, why am I taking melatonin? Again, our treatment is so comprehensive. Like, literally, I can see head spinning when people leave the office. Like, it's just a lot of information. So some people will take things, but they don't really understand why. So we're building out all of that education to explain why, what's the evidence, what's the data, how do we troubleshoot, how long do we do it, all of the specifics around each of those treatments. The initial intake and initiation of therapy is your first 3 months. So that's your deep dive. We really spend a lot of time with you, getting you going, getting on a diet plan, getting the supplements, figuring out how we fit in with everybody, getting all of those records, mitigating whatever damage has accumulated that are priorities. And then at the end of every 3 months is our major checkpoints. Okay. So those are, if you think about it as like the Grand Prix, those are your pit stops. We're going to run around the track unless you crash. And then when you come around every 3 months, we're going to do a check-in. We're going to maybe get imaging, we're going to get tumor markers, and you're going to have an appointment with me. And we're going to see, are things on track and good, like green light, keep going? Or do we need to revise? And if there's a crash on the field before then, if something majorly shifts and changes, we adjust that plan accordingly. So every month you can expect labs. Here are the 5 labs that we get every month. These are called the trifecta. This ESR is the erythrocyte sedimentation rate. The LDH is lactate dehydrogenase, and CRP is C-reactive protein. So any of you who's followed Nasha Winters, the trifecta is right here. We want the trifecta to be perfecta. So we're going to focus on these 3. We're also going to get a CBC with a differential, and we're going to get a CMP, which is a kidney liver study. Quarterly, we may expand those labs. We may check vitamin D levels. Like I said, tumor markers. We'll talk about Signatera a little bit and some of those advanced studies. So if you don't need to meet with me every month, we won't. If you do, we'll go to 3 months. And if we have major issues in between, we'll deal with those. So what do we do with your labs? We don't just get your labs and file them in a chart. They come through our desk. We're looking at the neutrophil to lymphocyte ratio. If any of you know Dr. Patrick Sion-Shang, no, soon, he talks about this a lot. So his BioShield, he's the one that was on Tucker Carlson. So neutrophils are your guards on the castle wall. If your body is a castle, the neutrophils are the guards on the castle wall. They are the ones that defend against every incoming threat or infection. Your lymphocytes are your attack dogs. So if there's a breach of the castle wall, so something gets through, these are your T cells, your B cells, your natural killer cells. That's your lymphocytes. That's what all of those different cells are made of. So most of the attention is given to the neutrophils. So when you neutropenic precautions, that is when the absolute neutrophil count drops below 500, which a couple of you that may have happened at one time. You literally go into the hospital, you start on antibiotics, your body can't fight off anything. Like you can't do suppositories, you can't eat sushi. It's a whole thing. But we're looking at the neutrophil to lymphocyte ratio. And I would challenge you, if this is a new term, look it up because a lot of doctors haven't heard of it. If you Google this, it says right in the AI summary that it has outcomes associated with cancer. C-reactive protein, again, is that marker of inflammation. These are signs in a SED rate. These are 2 different ways to measure inflammation. And when we start to lose control, these are going to go up. And I had somebody that a CRP is 150 getting chemotherapy. Probably not going to be super effective when there's that many inflammatory proteins circulating. So we really want to figure out, why is it going up? Can we get on top of it? And can we improve it? Sometimes that's more important than actually having the cancer treatment itself. Again, vitamin D levels for our patients, I recommend 80 to 120. Glucose levels, we do a lot of continuous glucose monitoring. We do some ketogenic diets, low carb diets, Mediterranean. We will customize that for you. And one of the things we catch a lot is on that CMP when the liver enzymes start to skyrocket and we lose control there. I'm going to be telling patients you need to pause on whatever treatment you're doing because your liver's in jeopardy. So this is another place that potentially that FibroScan, which is our liver scanning test, can come into play. But I've had people stop their chemotherapy. We start them on supplements. Their liver enzymes come back down. We've had 2 very successful outcomes. And like literally, I've told them, like, if you keep going, you're going to lose your liver. And they've thankfully taken my advice and stopped. And then they can restart treatment once we recover the liver, as long as it doesn't rebound again. Just so you guys know, a lot of times the perceived value of what we're doing is only what we do face to face, the time we spend in direct contact with you. But I can assure you this is an entire program. So we train our team extensively. We're still part of the Dr. Nasha Winters program. Most of us have completed that training, but we're still engaging in that. We have access to that. Dr. Paul Anderson is a naturopath. He wrote the IV vitamin book and has been treating cancer patients for decades through Bastyr University. As I mentioned, I'm an IMA senior fellow. We have a cancer working group. We're meeting tomorrow night to kind of discuss, what's on the horizon for that. We do daily education with our team. Every single day of the week, we meet for about an hour discussing a topic, discussing, patient cases on tumor board. So we spend a lot of time. So it's not just me, our entire team knows about all of these things I've shared with you. The nurses, when they look at your labs, they're looking at their neutrophil to lymphocyte ratio. They're looking at your liver enzymes. So they're helping me keep an eye on everything that's moving. So working with standard of care teams, this is where the fun begins. So remember, I used to be in that camp. I was a system doctor. I probably had a lot of the same misbeliefs that they do. So I want to give everybody the chance that they can learn, can change, and can modify. So some of them are receptive to what we're doing and some are not, but those are not our people and they might not be your people either. So at the end of the day, you need to remember you are a patient, but you are also a consumer of healthcare. And these people the doctors that you're seeing are not your parents. They can't tell you what to do and control you. They work for you. They are your consultants. So if they are not serving you in that capacity, you may want to fire them. Like if they're disrespectful to you over your choices, they probably don't belong on your team. If they can't have an open dialogue with what treatments you're on, you probably shouldn't have them around. Okay? We want to review all of the labs that you're getting from all your different doctors because they look through their lens, we look through ours, and we don't want to miss anything. And again, scoreboard, right? At the end of the day, our patients are doing exceptionally well. So we're proud of that fact. We've had some tough losses this year too. Not everybody has the outcome we want. There's a lot of people that get to us very late. There's a lot of people who've had a long journey. And there's just some people who have really, really bad problems. But at the end, the people who should and can do well seem to be doing well. So, how are we going to convince them? We want to buy in with successful outcomes. So, I encourage all of our patients stay in touch with your other doctors. We've heard it time and time. What are you doing? Your labs look phenomenal. Like you look great. What's happening? We've seen some pretty miraculous turnarounds, even if it doesn't change the overall outcomes, improving quality of life, the energy for patients. They just look a lot better. So other therapies we utilize and part of this, Helleborus is one of our favorites. This is Christmas cactus. It's kind of the yin yang to mistletoe. So this is cooling and anti-inflammatory. Mistletoe is an immunotherapy. It's actually standard of care in Europe for many cancers. We've had a lot of success with that. And it's a subcutaneous injection. So it's approved in the United States as a homeopathic remedy. And we use it off label by injecting it. So we've seen a lot of success with that. Again, melatonin, DIM, I3C, and CDG calcium D-glucarate. This is what we use to help detoxify estrogens and get them out of the body. A lot of milk thistle, great when the liver for liver support. As I said, vitamin D. So what types of cancers? We have a lot of people call and ask us this, and my answer is always the same. We don't treat conditions, we treat patients. So there isn't anybody that we can't help. We may have never heard of their tumor, but if their vitamin D is low and their nutrition's off and their A1C is 7, we can probably offer something to their treatment. So every situation we have something to contribute to, something to improve. Obviously, the most common things are the things we see most commonly. You can see the things that occur most commonly are what crosses our desk. There's also something I want to interject with right here, and I didn't make a slide for it, but it is looking at the oxidative stress of the body. So oxidative stress, think about it as your car engine smoking. Okay, so if you have a body that has inflammation out of control, what will happen is that engine's going to smoke. right? And it's going to give a signal. Well, our body doesn't smoke, but what it does is it creates inflammatory markers, things like oxidative LDL, LDH, lactate dehydrogenase goes up, myeloperoxidase goes up. Some of those advanced labs that we check, CRP goes off the roof. When we start to see all of those things shift, when you, I think of it as a long, skinny road. You don't want to get pushed off one side by a cancer. You don't want to get pushed off the other side by a treatment. So if your body is shifting into oxidative stress, and we're doing things like chemotherapy that are also oxidative stress, we can push too far and make someone sicker. So there's a point at which in advanced stage 3 and stage 4 cancer, we can't do those treatments. You can't tolerate IV vitamin C. You're not going to tolerate chemotherapy. You're not going to tolerate hyperbaric oxygen or EBU. We've got to pull you back from the brink and get you back in the middle of the road where now you can tolerate a little oxidative therapy. So that's a concept that is even a little tricky for us, but the system doesn't even acknowledge it, right? You walk in and you've got a colorectal cancer and you weigh this much, this is the dose you're getting. Regardless of any of your labs, your nutritional status, your genetics, you're just going to get what the path report says. And it's one size fits all. We really customize things for each individual. So again, there are patients who come to us very late in their stories. They don't want to give up. They want to have relief. They've either been abandoned by the system or, again, not ready to give up, and there aren't any standard of care treatments left. So we've developed the HOPE protocol for these patients. So basically what it means is we want to be very realistic with expectations. We don't want to necessarily do all those deep dives and things and offer treatments that they're going to be too sick to tolerate. But yet things like mistletoe can bring a lot of relief. Helleborus. Sometimes my team will see someone and say, hey, they're scheduled with you in a month, but I'm not sure they'll be here. And within a month, they look great. Again, just not giving up on people and where can we gently nudge to see if we can get some symptom relief and so pain and discomfort, energy and stamina, quality of life back is important. Anxiety and distress, right? If you have to engage with the system, it is not the most friendly. And certainly when you don't feel well, it's even worse. So we provide that easy access and just lower the temperature in the room quite a bit. So we've been doing this now about a year and a half, maybe almost 2 years. So there are some lessons that we have learned. A lot of people find us looking for ivermectin and fenbendazole. Fenbendazole, fenbendazole is not prescribed. The patients can buy that over the counter. We actually recommend they do mebendazole, and my team spent a lot of time finding a pharmacy with an affordable mebendazole. A lot of time. We called a lot of pharmacies. I incorporate ivermectin and mebendazole. You do not see me on social media saying we're curing stage 3 and stage 4 cancer with this protocol. I will not do it. I do not believe those results are truthful. And I'm very honest with patients when they walk in the door. I feel like our care is so much more sophisticated than just that. We have so much more to offer patients. So I do use these medications. I think they're really good to address stem cells. I think they might have some active anti-cancer properties. I think they're very safe. And so we do incorporate them, but we're very honest and clear about what their role is. And it is not live whatever life you want until you have stage 4 cancer, then take a few ivermectin pills and everything will be fine. I think that's giving people a lot of false hope, and patients not trusting the system are now trying to treat their own cancers at home, thinking that's the end all be all. And it's truly not. Trusting and following your gut are the most important things. So every patient that comes to us has a budget. They have an amount of time they can sit in a chair, and they have a number of pills they can swallow per day. They also have a preference on where to go. So I want people to be very honest with us about those parameters. If vitamin C at, what is it, $2,000 a month doesn't fit into your budget, then we won't recommend it. Or we may recommend it, but we understand everybody's got a budget to follow. And we want you to follow your gut too. So if you want to be standard of care, that's okay. If you want to be integrative, that's okay. There's a couple of points where I say you need to go find those people. You need to have them consult with you to clarify maybe some misunderstandings you have or clarify your options. We actually had a really sad case of a gentleman who came in with some abdominal pain. And my team did a really good job working him up. Like we knew him, he was a friend of the clinic. We worked him up. He unfortunately had a liver lesions and a pretty clear colorectal cancer. So my team worked very diligently to try to get him and all the things that he needed, which takes some time in the system. In the meantime, most patients would want to get started with treatment right away. And so we said, you absolutely can come in. We can start IV vitamin C. We can start this and we can start that. Somewhere along the way, the patient, again, this is a very emotional period. So, the patient came to a perspective, talked to somebody, consulted with somebody, and was in the misunderstanding of what we had told him, what the treatments were, that we hadn't sent him to an oncologist. So everybody goes to a medical oncologist, everyone goes to a radiation oncologist now. We want everything to be clear and on the table. So there's no room for misunderstandings during a very emotional period. We will help you vet out other options too. We've had some patients going to Mexico. We've had some patients send me places and I'm like, I wouldn't go there. We've had patients, I believe, have been fleeced out of $60,000 getting repeated PET scans that they didn't need. So we will help you vet that and guide you to, hey, that sounds like a great option. This one I'd be a little bit aware, beware of. One of the things that's very frustrating is a lot of things in standard of care oncology is unknown, right? They have a lot of studies, they have a lot of data that they're going on, but this is still humans and it's the art of medicine. And there's so many hundreds and thousands of variables that we cannot account for. So when an oncologist comes, literally just talk to a patient and said, my doctor said I need this and this or I'm going to die. How do they know? You're not dead now and you've had it for years. How do they know? So I don't like it when somebody comes with that kind of certainty, giving someone, this is your pathway unless you do what I say. To me, that is very fear mongering. It is counter to what we're trying to do. Obviously, it's very emotional, but the more we can take emotion out of it and present facts and options, the better people will be. But integrative oncology is even more unknown because there aren't these big studies to depend on and rely on, and there's very little financial incentive. So, patients will ask me, how much ivermectin should I take? And my answer is, I don't know. What we have to kind of come up with something that seems reasonable, feasible, and, within the lines. Our approach is not for everyone, and it evokes a lot of anger sometimes. If you look at our Google review, we have a very negative review. I think you can draw conclusions of that situation. Not all family members are supportive of what we do. Some of the angriest people are people who maybe don't have the financial resources to participate in an integrative cancer program. So they think we have something that they can't access. That can generate a lot of anger. And, we hate that because we would give it away for free if we could. We try to make it, my goal is to make it accessible to hardworking people who've shown up for work their whole lives and now have a problem and they want to solve it in a certain way, that we are as accessible as possible for people who fit into that category. So we deal with those angry people sometimes. So the lessons we have learned, again, there's a lot of bias. So just keep that in mind as you individually or you hear of things. If a patient progresses while on an integrative therapy, well, it's hocus pocus and doesn't work. But if they're on chemotherapy or the newest immunotherapy and they progress, well, it's just a very aggressive cancer. It was just too late. So I only point that out. That's not going to change. That's always been the case when you're kind of outside of the system. But just to bring it to your attention for some context. All right. I'm going to ask you all for a favor now. If you have paid attention to our social media or our email this week, I would appreciate a Google review. So if you can take 60 seconds tonight and please give us a Google review, that is really helpful. We were banned from Google for 18 months based on our position. They would never tell us why or give us a chance to rectify it. So I want to break their algorithm and show up on everybody's search. And the only way we can do that is by you, if you've had a good experience with our clinic, sharing that. If you are not getting our emails, please send us an email to hello@jamesclinic.com and I will add you. On Sundays, usually Sundays or Mondays, I send out an email. There probably will be an email that should go out tomorrow too with a recap of this. If you've been paying attention, our website is being actively updated daily. So I'm actually going to go to that really quick. Oof, it even updated since we've been on here. So this is exciting. Stop sharing and I'm going to reshare. Wow, that was fast. This looked different an hour ago. So here is our new website. So it is a bit rearranged at the top. All of our new integrative testing is listed. Our approaches to care, the Terrain Cancer Support, and the HOPE protocol are both on our website now. News and events. So you can sign up for these Zooms right here if you know somebody who might want to sign up. And then our new blog posts. So it looks like we might need one little tweak there. So lots of new things. We also have a careers page. So one of our biggest challenges right now is we've been growing so fast. We actually need people to help us support our terrain cancer patients. So we have a careers page. So if you know somebody who would be a good fit for our clinic, please send them our way. We would love to talk to them. I think I read something today that like less than 0.5% of people screened actually meet A-team criteria. So we've got to screen a lot of people. And we will do that because we're committed to the growth and the good things that are happening. There is a Lyme event Saturday, February 21st. I'm going to share that really quick too, just so you've seen it. You are all welcome to register for that for free. Share that with anybody you know that struggles with a Lyme situation. I'm going to get to your Q&As here in just a minute. I just want you to see what this looks like. So Lyme in Missouri, what your doctor didn't tell you. A very prominent Lyme physician just passed away unexpectedly in our area. Very well respected. Patients loved him. Apparently the practice is closed. So we know a lot of people are looking for this right now. So Lyme in Missouri, again, free registration. It's going to be the three of us ladies breaking down the myths. It's going to be really high, fast-paced, high yield, what you need to know. Okay, we're almost through here, and then we'll take questions. Okay, you can join our Facebook community if you haven't already. If you're on social media, feel free to join our Facebook community. And if you go to our YouTube channel and subscribe, you'll get notifications when like I'll replay or get this produced and post it. Monday nights we've got. So what a whirlwind, but that Google review, I would really appreciate it. You do have to have a Google account, I believe, in order to do that. It takes about 60 seconds. So you just Google James Clinic. We have two different options for clinics. You can pick Sheraton or Chesterfield, either one. It just helps us out so much. So appreciate that. All right, questions. What is IMA? The Independent Medical Alliance. So the FLCCC was the Frontline Critical Care, COVID Critical Care Consortium, something like that. So that is a group of rebel doctors who are out there really trying to just bring honesty to medicine, taking out the politics, getting down to what does the data show? What is best practice? Really advocating against things like the COVID shots, mandates, getting to informed consent. We are working with policymakers in DC. So you have seen some of the results of some of the senior fellows' work. I will tell you that. And it's imahealth.org if you want to learn more. They have great webinars every Wednesday night at 6 p.m. Central, I believe it is. So on imahealth.org, and you can sign up to get on that list too. I did a webinar, I think I've done 2 or 3 now. About a month ago, we did one on peptides, and last year we did a couple on cancer care, I believe. So Teresa Kern, go for it. You are muted, so make sure to unmute, and you have the microphone. Did you have a question? She might have bumped it. Okay, so what is IMA? Any other questions tonight? Melissa, I've read over many of those online protocols and I didn't think they can do enough standalone. Again, there's no protocol, right? Nothing's individualized because everybody responds differently to things. You just need that individualized care. You need that tweak. You need that fine tuning. It's like a car engine, right? You can't just like you can have a Chevy or you can fine tune that. Steve, you busted me, man. Steve asked, have you received the second MDI pump in St. Louis? Yes, we have. So we are working on that staffing issue. The team should be reaching out to call and get you scheduled for that. So don't jam the phone lines tomorrow, please. But yes, they are working through the list to get you scheduled. We have the second pump. We have 2 more coming. Breaking news. So we do have 2 more pumps coming. We know you guys want it. We know some of you, the responses have been absolutely incredible. Everything from more energy, neuropathy, nobody can beat what we can do with neuropathy right now. We have people who've had dementia that are doing, I would call them remarkably better. Yes, it's very rewarding. Teresa, I didn't see you talking, so you can type it in the chat. I think there might be a problem with your mic, or you bumped it and can't hear me. Oh, Doris can't figure. If you guys stop in, we will help you with that, Steve. Next time, they can kind of point you in the right direction. You have to log in with a Gmail account because it's a Google-based thing. So if you Google here, let me show you, and then I'll answer this question. Let's see if I can share my screen, which is always a little bit risky. Here we go. Share my screen. So if you go to google.com and then type in James Clinic. So this should pop up. You can see we have 34 reviews. So you can go here to reviews and write a review right here. So that's how you do it. And you can you'll probably pick that one, but you can, if you're mostly virtual, you can pick either one. It does not matter. It helps us either way. All right, next question. Is a training program possible remotely, or is best option to come into the clinic? I think the best option is to come into the clinic for sure. If you are not geographically close, what I would recommend is coming in for your initial, even if we get you started virtually and then you come in to meet with me and maybe get a couple of infusions under your belt, just being in our space and knowing our team in person, I believe helps so much more than just those people who, oh, okay, Teresa, no problem. Those people who are virtual that we really love and have engaged with, they just don't seem to do quite the same. I'll just leave it at that. And I think some of it's just that they can't come in and get loved on when they're having bad times, and it's phone calls and virtual, and so things like that. Okay. I'm not a patient yet, but I got an email about special testing, 4 different tests. Gary, that is a great question. It is actually open to patients who are not currently on our concierge program. So we are working on a special introductory offer for patients who have not yet signed up for concierge. We gave our concierge patients first round at that. So I will get that in the email tonight, an intro offer for the testing. But any patient now can come in and do any of our testing without being concierge. So that is open. And we are going to make that clear on our website. These are the things you can do. You do not have to sign up for a concierge plan. These are the things that you need to sign up for concierge. So you can do vitamin infusions, hyperbaric oxygen, the testing. We have a new lab review only appointment. So you'll did an intake, we'll order our panel of labs, standard panel. You'll go to LabCorp and get those drawn, and then you'll come in and you'll have an hour appointment with us. We'll do a consult and a lab review at once and lay out all of your recommendations. Really nice option for a lot of people who just don't feel like they need comprehensive care. I think they might, but if they don't, that's a great way to get their foot in the door and get that. You need the Lyme link. I will drop that here. So if you want to register for the Lyme event, that is in the chat. There you are. Got it. Not a patient. Doris, you can do it. I promise we'll help you though. Okay. So we answered that question. Any last call for questions tonight? Thank you guys. I appreciate you. I'm getting really good feedback on these. We're using January kind of just to build that foundation and that base. And then as we go next week, I'm hoping that it is going to be, who is Major Mike Hall? He is the director of our JC Elite program. He will be hopefully here if he is not in the military doing something kind of unpredictable these days. But he will be here talking to us. And after that, I believe we are doing the MCG, the multifunction cardiogram, the first week in February. So lots of exciting things coming. We will be busy during the Lyme event. Will it be on YouTube? I have not decided where that's going to go afterwards, but I think if you register for the event, you'll still get the recordings afterwards. So you might still want to register if that information is interesting for you. Maybe put the PDF in the email newsletter. Yes, some of these documents are just confidential, like we don't want them out on the internet. So I just want to be mindful of how we're distributing those things. So we're very blessed to have access to them. But thank you. We appreciate you being here. Google reviews. I'm going to close with that. Thank you tonight. God bless. Good luck. And I will see you next time. I will leave the window open for a minute. And it was in the email earlier this week, and I'll put it in the email again. The link is not working for Lyme. It is working when I click it. So try again. Oh, you know what? Let me check one more thing. Hold tight. Watch in your emails and make sure you sign into Zoom, which we are. I don't know. Maybe once you close out of this, save the link and it'll go back. But there will be more emails coming up, and we can get you signed up if you're in the office too. It's always on our social media, so you can go to our Instagram or our Facebook page, and it should be there as well. So please do register. Again, it's gonna be high yield, fast paced. Hit a topic, hit your 3 top points, and move on. It's not going to be a boring medical talk per se. Thanks again, guys. See you next week, hopefully with Major Mike Hall. If not, we will pinch hit and do another fun topic. So good night and God bless.